Oxford. And I've been an obstetrician for far too long, much longer than most of you have been born. I've been an obstetrician since 1992. And my connection with Palestine, with Gaza particularly, is that I've been teaching there for a number of years. Since 2016, I was part of the Oxford teaching group, and had the pleasure of visiting Gaza since then, and teaching undergraduates and postgraduates, mostly ward teaching and OSCEs. And then last year in sort of December 23 to January 24, I was part of an emergency medical team in Al-Aqsa Hospital in the middle area. And so saw firsthand for a very, very brief moment compared to what you are experiencing, the horror that is going on. And I've been asked to talk about women maternal health in conflict, but I wouldn't pretend to be anywhere near an expert. And the people, the obstetricians, the midwives, and those in primary care delivering maternal and neonatal and child health are the experts in this. I don't think I wouldn't even pretend that I have any understanding really of the difficulties, the complexity, the challenges that are being faced. But obviously this is also very much seen in other conflicts and in a worldwide context. So who's on the call? What are you undergraduates? Who's here, if that's all right? You can either write it in the chat or please, feel free to speak freely. There's very few of us, so let's make this what you want it to be, and we can make this a sort of question answer session, and we can whatever would be useful for you rather than a didactic lecture, which I always think is, you can read that in books and journals. So who are mainly on the call? Are you mainly students? Too shy? Or maybe can you hear me?
Yeah, I can still hear you. Yeah, guys, feel free not to be shy. The best way to move this forward is if we're interactive. So use this opportunity. And feel free to type in the chat if you'd prefer that.
Yeah, no, that's absolutely fine. If you've got enough Wi-Fi, do just come on, take your cameras, turn your cameras on and your microphones on, because this is all about just us talking together and answering any questions that you may have. So I'm going to share. I've got very few slides actually. I'm going to share a couple, and then hopefully we can start having a chat about things. I'm not brilliant at. I have to say, I'm really sorry. I'm not brilliant at this because I use Teams all the time. How do I share slides on here? Do you have to give me permission, or I can just share?
I will make you co-host, but I think it should still work. There should be a share screen.
Yep.
Button.
Oh, fine. Thank you very much. Yeah, I have. I'm just trying to find. Too many talks. Can you see?
Yeah.
Lovely. Okay. So how do I turn down the, sorry, that's slightly annoying. Oh, am I sharing? I've lost it again.
Yeah, it's still showing the screen.
I can't see it. Sorry. There we are. I can see it now. That's better. So the first thing to say is that death in conflict is unfortunately incredibly common. And this study that was out of an interagency working group looking at conflict across the world, and it looked at 29 countries where there had been UN humanitarian appeals for because of conflict. And I thought this was really startling that 64% of global maternal deaths and 50% of newborn deaths and 51% of stillbirths are in those conflict zones. So that is a huge burden of mortality and morbidity, and something that I think is, clearly absolutely shocking. I can't. I'm really sorry. I don't know why this is not moving on. I may have to stop sharing and start and try again. I'm really sorry. So I'm going to make you do the work. What what in your experience, or what might be the impact um, of conflict on maternal and child health? Sorry, I can't see anybody at the same time. Are you able to? Right. Have we got anybody? So what might be the sort of things that you think might impact? I'm not sure that anyone is hearing me actually.
Yeah, I can still hear you, Dr. Harrington. I think we've just got a bit of a shyer group. That's all.
Um, are you able to? Are you happy to look? I promise you, I won't bite. Honestly, are you able to show your cameras if that's possible, or do you just want to write in? Do you want to just write in the chat?
I think we've just got one message in the chat. Can you see it, or would you like me to read it out?
Yeah, go on. Yeah, tell me.
Um,
Tell me.
so Zara Natcha said, "Hello, doctor. I would like to introduce myself. I'm not a student and I didn't work after the foundation year here."
Fine, that's fine. That's lovely to meet you. Everybody is welcome. Absolutely everybody is welcome.
She said she's a mum, so that's why she's not able to
Oh,
turn her mic on.
fantastic. No, that's absolutely fine. That's
But that's
absolutely
also
fine.
fine, Zara. Like, it's fine to have background noise. That's
Yeah,
completely fine
we
as
don't
well. So
mind. We
don't
don't
worry.
mind. It's not a problem. So what might be the immediate things if we think about the impact of conflict on maternal and child health? And we can all see it on our screens every day. And of those of you, do we have some of the students from Gaza? So if you think about things, there's obviously the direct impact on conflict, isn't there? So the deaths due to trauma. What about nutrition and things like that? Access to nutrition, and that's a particular issue in Gaza at the moment, isn't it? There is the impact of not being able to access healthcare. Of one of the things that often happens is that women's services, because of hospitals having to deal with the trauma that's in front of them, and dealing with the mass casualties, that birth centres or maternal health or giving birth are moved out of those acute emergency hospitals and often moved into smaller places that were never able to take the volume or the high risk cases. They weren't sort of designed for that, but simply because there isn't room. I know certainly that's happened in Gaza, not only because more than 90% of hospitals are not functioning in the way that they were able to because of the attacks on them, but also because the hospitals are overwhelmed, dealing with trauma, and so maternity services are often moved out. So there's sort of simple things. There's the direct causes, there's the indirect. So there's the impact of things like nutrition, of being able to move around, transport, of access to, to medical supplies. As we know, that is a huge problem in Gaza at the moment, but not getting drugs, medications, supplies, staff in the right place. Simple things like antibiotics, intravenous drugs, things that might stop infection or hemorrhage, thrombosis, all the major hypertension, all the sort of major killers of women. Who's going to? We got any other ideas?
I'm not sure if you can open the chat, but there's also 2 more things from Zara. She said infectious diseases and hygiene.
Absolutely. And what do we know about those? What are the sort of things that you think might be, might have an impact on that? Infectious diseases, absolutely. We've got displaced people in conflict zones, haven't we? They're away from home. They may be in camps. They may be outside camps. They may be just in temporary shelters. The density of people living together, the access to sanitary, to toilets, to wash facilities, to clean water. So communicable diseases, things like diarrhea, waterborne diseases, respiratory infections, all of those things are going to have a major implication on the health of a pregnancy, aren't they? And on newborns who, as we know, are particularly vulnerable in those settings. That's right. So infection, sanitation, nutrition. What else? You'll have to read it out to me because I can't see the chat.
Yeah, there isn't anything else in the chat yet.
Okay. So I'm going to go on to so there are many things I think we're saying that can impact on both mother and baby. And one of the other important things is that we know that these things, don't go away. And I thought I'd show you this, which is this is what happens to vulnerable mothers in humanitarian settings, conflict being one of those, and this cycle of vulnerability. And we know that from other conflicts that the data suggests that miscarriage rates are going up, and we certainly know that in Gaza, for example, that there is growing evidence that definitely is the case. So we know that vulnerable mothers, are with nutrition and infection and all of those other things that you said, and lack of access to antenatal care, are more like are definitely vulnerable. So miscarriage rates go up. Maternal death, we know, can go up as a result of complications of pregnancy, hypertension, preeclampsia, thrombosis, hemorrhage, all the usual things. Stillbirth also increases, and I think in other settings we know that there is very good evidence of all of those things happening. And then for those mothers who get through to giving birth, they are more likely to give birth too soon to a baby that is too small. And the small, vulnerable newborn is much more likely, unfortunately, to succumb to complications. So we know that neonatal death is also increased, and that is multifactorial. It may be because it's a small for dates baby. It may be because the baby's been born early. It may be because of poor nutrition. It may be due to infection. And so there is a very high increase in neonatal deaths. But of those children that survive, it isn't over. And we know that there is a ongoing cycle of vulnerability, and vulnerable children grow up to be vulnerable adults. They are more likely to have chronic illness. They are more likely to have stunting. They are more likely to have malnutrition. They are actually more likely to have a reduced life expectancy, and that goes on into causing, a result on the sort of economic and human capital cost. So it impacts on society. So these things, snowball. They are huge and growing, and so it is really important to put in whatever interventions can be. I mean, the main intervention being stopping conflict. But there are also the WHO and UN have also put in mechanisms to try and improve care. What do you know about the sort of general guidance for antenatal care? Are any of you aware of the WHO guidance and what that says? Sorry, I got my. I've lost. I think I've lost. Can't hear anything. I'm terribly sorry. I seem to have lost.
I think someone had their mic on, but I'm not sure if they were trying to answer.
Oh, okay.
Don't know if it was accidental.
No, that's absolutely fine. So talking about antenatal care, because we can't really talk about what one can do in a conflict unless we have a sort of an idea of what what is recommended, and therefore what can be done to try and meet some of those things. Do any of you know sort of, for example, the sort of the key things about antenatal care? What do you think it might start off with?
Someone's just written screening in the chat.
Absolutely. So what do you mean by screening? That you're absolutely right. Screening is a really important part. Ultrasound, yes. So the WHO recommends one ultrasound before 24 weeks. And there's lots of things that an ultrasound can do. What really useful things could an ultrasound do? So AFI, yes. But if we're thinking about at the beginning of pregnancy, much more kind of basic than that, actually. Fetal heart, yeah. Is there a viable pregnancy? That's right. Is this a viable pregnancy? And what might that be helpful for? How many hearts? Is this a singleton pregnancy or is it a multiple pregnancy? Diameters. Yeah, so you're thinking about measurements, aren't you? So why might that be useful to know some measurements? What might that what might that tell you if you did an early scan? It can tell you estimated fetal weight, but if you're doing it early and the recommendation is if you're looking at bare minimum, one scan before 24 weeks, and that can tell you so many things. So it can tell you how many babies there are, whether they're viable, if they're alive or not. Somebody mentioned placenta. It can tell you if the placenta, where the placenta is it low or is it out of the way? Because that's an important thing to know, isn't it, when you're planning birth or place birth. It can date the pregnancy because that's really important, isn't it? How can you know if a baby is small for dates when you're measuring a woman's abdomen, when you're measuring the symphysis height, if you don't know what the dates are? So if you can, obviously you've got women's dates, but also you can confirm that, or you can do an estimated delivery date, and that's a very important part of the first scan. You can also pick up abnormalities, can't you? Now that's probably only important if you're able to do something about them, but it might, we're talking about conflict here, so perhaps that isn't as relevant as outside conflict, but picking up abnormalities, you can plan to deliver the baby in a place where there might be the neonatal services to help with whatever that abnormality is. And then other people mentioned other things like fluid volume. You're absolutely right. Is there normal looking fluid or abnormal looking fluid? So those are the key things that we can diagnose on that one scan. So it can tell you so many important things. So a scan, yeah, that's definitely part, and the recommendation is at least one scan before 24 weeks. What else might be important? Really early in pregnancy. That's a very common problem worldwide and is probably responsible for many hundreds of thousands of maternal deaths and is incredibly easily treated, even in humanitarian settings. Blood group and rhesus, yeah, you're absolutely right. So knowing what a blood group is, knowing the rhesus status, and that's important because if we've got a mother who we know is rhesus negative, she could be having a rhesus positive baby, and to prevent rhesus disease in subsequent pregnancies, then we can target which mothers to give anti-D to and prevent that rhesus disease. Absolutely. What else can we do really early in pregnancy? So TSH wouldn't be necessarily a routine. I mean, it might be indicated from a clinical history. You're going to take a booking history, aren't you? Yes. Somebody said iron and folic acid. Absolutely. So that is just so important. So one of the most important interventions that you can do, and what is recommended as part of the WHO is giving iron and folic acid supplements. How many women worldwide, particularly in developing countries, in low income settings or medium or low income settings, are anemic? Any idea of the sort of prevalence of anemia? It's incredibly common. It's about 40% of women in pregnancy, and that certainly is what your data from the data from Gaza showed us, that about 40 before this conflict, about 40% of women in pregnancy in Gaza before this current war were anemic. And so a simple intervention of giving iron and giving folic acid early in the pregnancy may prevent death. And that is even more essential in times where, you know, access to antenatal care, the risk of bleeding, the access to theatres, you know, all those sort of life-saving things, the lack of drugs that may prevent hemorrhage or may treat hemorrhage are in such short supply that actually making sure that you're, you know, trying to give an intervention such as iron may prevent deaths. And it sounds so simple. And somebody's also mentioned about vaccination. Absolutely. What kind of vaccinations particularly? Somebody's written so much, absolutely. What vaccinations would you like? Tetanus, absolutely. Diphtheria, absolutely. So, tetanus being a really fundamental one. You are absolutely right. Um, but well, and that is something that should be checked at booking. You know, it has what is the tetanus status, and using it as an opportunity. And one of the things that WHO talk about is contacts. And contacts can take place in many settings with a woman. It might be in her home, it might be in community clinics, it might be in it might be in a hospital. But at each of those contacts, it's this. There's an opportunity to do many things, and the early ones are taking a really good history. You know, how many babies has that woman had? Has she had a cesarean before? What is her health? Has she got health risk? Has she got heart disease? Has she got diabetes? Has she got a family history of diabetes? So all of those things that you can check out at booking. And then somebody talked about screening, and you're absolutely right. And getting a, you know, checking, are they anemic? Can I put something in place to prevent that? Are they vaccinated? Have I got an opportunity to vaccinate this woman? You're absolutely. So, you know, these interventions are life-saving, and they sound simple, but they are incredible. You know, they are incredibly effective and relatively, you know, low cost. There's also another opportunity for screening for other diseases at the time, and that depends on the context, doesn't it? And somebody's put their syphilis, HIV testing, exactly. And you know, these are context specific, but we know that they're preventable, they're treatable, and so taking the opportunity to be able to test for things that you know that there are interventions for is incredibly useful. TB, if you're in a high TB, an area where there's high TB prevalence, of course, TB screening, hepatitis, absolutely. And blood group and antibodies, as you mentioned, incredibly important, because you can target those people that might need might need intervention with anti-D to prevent future pregnancies from prevent sensitization and future pregnancies from being impacted by rhesus disease. Sexually transmitted diseases, absolutely. And we know it's a fact, unfortunately, that gender-based violence or intimate violence can be much more prevalent in times of conflict. Sexually transmitted diseases, you know, sensitively asking about it, and maybe even screening and treating means that you know, there's an opportunity for those things as well. Absolutely. So then moving on, so we've talked about you know, the opportunity for screening, the opportunity for an ultrasound if it's available. Now that obviously may be incredibly difficult, but then what would be the usual number of visits that would be recommended if we could possibly try and deliver those? Any idea? How many times do you think we need to see a woman in pregnancy? Yeah, absolutely. So 8 visits is what's recommended, and that's been shown because that number of visits decreases the risk of stillbirth and improves outcomes. It used to be prior to 2016 that 4 were recommended, but that has increased, and it was increased because it's been shown that that number of visits reduces those poor outcomes. And in fact, greater number of visits, the data isn't there. It may be that in more visits than that may have some impact, but there's actually no data that suggests. So that's why the number of 8 was chosen. I don't know what IBNO complains at present. I'm not sure what that. Sorry if I don't understand. And then I'm going back to other things that we can do at those visits. So what are the sort of things that if you had an opportunity, a contact, even if it isn't in the planned normal way, which may be the issue in conflict zones, in that women can't access the normal amounts of care for all the reasons that we've discussed. But what sort of things would you like to do as a bare minimum if you possibly got access? Somebody mentioned it above. What are the main killers of women? What would you like to know? What happens at an antenatal check?
Can you repeat the question? Or really like re-say it somehow?
Oh, okay. What do you think? What happens at an antenatal visit when the midwife sees a woman? What are the things that she would do at that contact that might be actually life-saving, that make a difference to improve the outcome of a pregnancy, and
I
that you
think
could
we
take an
should.
opportunity?
Sorry.
Yeah, go on.
Please continue. I think we should always check the vitals and the blood sugar in case for eclampsia, pre-eclampsia, and for diabetes, gestational diabetes, and gestational hypertension. We should
Absolutely. So blood
also.
pressure. Absolutely. So talk to the woman. How is she? Ask her. Patients always tell you this, that will always tell you what's wrong with them. So they might complain about, somebody's mentioned about fetal movements. They might tell you about feeling really tired. They might tell you about pains that they have. They might tell you really bad headaches, or that that they're swelling. So talking to a woman and finding out about her symptoms. And you're absolutely right. The things that antenatal care is aimed at trying to pick up is hypertension, which remains the second leading cause of maternal death worldwide. So blood pressure and urine analysis, if you're able to do it. But those are really, really important things. But somebody mentioned about diabetes screening. You're absolutely right. If there is hyperglycemia at any point during the pregnancy, then that would be enough to be able to say in this type of setting that there may be gestational diabetes, and trying to put some interventions in place for that. CBC, absolutely. I think CBC means hemoglobin. I think we all call things, I think we call it FBC. So I think you mean checking a full blood count. I hope I'm getting that right. Please, apologies if I'm not. Please correct me. So you're right. Taking the opportunity to check for hemoglobin is really important. That's right. So those sort of basics are life-saving, and if possible, you can then put interventions in place. You can pick up preeclampsia with high blood pressure and proteinuria. If you've got access to medications antihypertensive medications, you can then to instigate those, and a plan to monitoring blood pressure in order to try and treat hypertension, because we know that treated hypertension will improve outcomes for mothers and babies. And then absolutely doing an abdominal. So as part of your examination, it's doing an abdominal check. And that's particularly trying to pick up signs that there is a small for gestational age baby. So you want to measure this. It's done in different ways across the world, but in some areas that it is with symphysofungal height, and basically the height, symphysofungal height should be approximately equivalent in centimeters to the number of weeks gestation, plus or minus 2 centimeters, or abdominal palpation, and that will depend on the setting. People are used to different things, but a way of measuring that's reproducible fundal height and checking whether a baby is growing normally. And one of the things that we see in humanitarian settings, particularly in conflict, is that small for gestational age becomes increasingly small for gestational age is a very prevalent problem, and that's because of all sorts of issues, nutrition being one, high rates of stress in mothers, maybe access to supplements, micronutrients, supplements. It may be as a consequence of exposure to toxins in the environment that they're living in. So there are all sorts of, it may be because of chronic infection, it may be because of anemia. And so those are the you can pick up if the baby is small for gestational age. What you can do for those interventions is harder, and it depends on what resources you have available to you. But those are the sort of things that should be done at every antenatal check. Absolutely.
Can I add also that we have to ask about the previous pregnancies and what events have happened? Because I think for
Absolutely.
the DVT management and prophylaxis, I think we should consider parity in scoring. So we should like give antithrombotic or or like drugs for the DVT prevention.
Absolutely. The most important thing really at the beginning is to take a really good booking history, isn't it? And that's when you first see your midwife as soon as you're pregnant. Those sort of risk assessments, which is what you're talking about, what their parity is, what the previous medical history is, what previous obstetric history is, what drug history, what family history, what social circumstances. Does a woman smoke? All of those sort of things are going to give you information that it is going to allow you to risk stratify. In conflict settings, I don't think there's anybody that's not at high risk, particularly, if there is the issue around, safe water, nutrition, environmental factors, exposure to infection, high risks of anemia, lack of access to drugs. All of those things are going to impact on your risk stratification in pregnancy, and then what you can do about it. So what might you want? What kind of interventions do you think might be, or what do you think that that experts in this field might want to put together to help in this kind of context? What would you like if you were the doctor that was, you're an obstetrician and gynecologist, you're now suddenly being faced with having to work in these extreme conditions, within a conflict setting, what would help you to do what would help you to give the best care that you could with the limited resources that you had?
I think, I don't know, like the nutrition is a huge part and the vitamins. I think contacting any humanitarian aid organization would be appropriate in this case. But I do know that there are many restrictions on the border. So I think what I can do as a single physician is like a meticulous follow-up for the patient and observing every minor difference in the patient.
But the first thing we might want to do is actually know what's out there, won't we? What guidance there is, and there is guidance. You know, there are, and I would recommend if you're interested in this that there are many good things to, you know, there are some good resources to read, and guidance. I would look, you know, if I don't know what to do, if I have a new case that I work in high risk cases, and so I'm always getting things that, you know, actually I haven't dealt with before, or I have, but actually things have changed. You know, the evidence has changed, and what we do is look out there for experts, don't we? And WHO or UN or other sets of experts will often have already set some guidelines to help us in these situations about what to do. You know, what is minimum, what is they will have already got expertise in how you organize, you know, care where possible to do so. And we all know that, you know, that conflict has huge implications because of safety, and sometimes and it is often not possible to do, but there are experts out there who do this all the time, and so there are, the WHO particularly has really clear guidance what drugs are needed, you know, to be brought in, because the trouble is if you have lots of different NGOs and lots of people all wanting to help, they might not necessarily get in what's needed. So you need some kind of structure and system, and there are very, you know, there are excellent mechanisms, particularly around WHO recommendations of what drugs are needed for maternal and neonatal and child health, what equipment, you know, is bare necessity, even what, you know, what teams are required, how to set up clinics, where those need to be, you know, all of those sort of things. So we you know, we go to the experts on you know, what is needed. And if we're thinking about, if you were asked what drugs would I need to bring in for safe childbirth, what other things would be the top of your list? And we've talked about some of them already at the beginning of pregnancy. We've talked about iron and folic acid and nutritional supplements. What about if we're coming to around childbirth? What might make childbirth safer?
I haven't been in the start of the lecture, but I can like add for and like the vitamin K for the baby.
Okay, so we can think it as maternal things, can't we? And so maternal things and neonatal things. So for a mother, what would you want to see?
I think the medications for
Yeah, so let's think
uterine.
about drugs. What do you think about drugs that might make childbirth safer? What drugs might help that you would want on your list of things? Somebody's put penicillin, absolutely. Antibiotics, I think we can say, can't we? I mean, we know that all the things that we've said that might impact in conflict, the you know, the sanitation, the lack of access to water, the lack of access, you know, the high prevalence of infection. So
I think drugs for uterine contraction.
antibiotics, okay, yeah. So you were talking about, so contractions, yes. So what kind of drugs might be useful for contractions?
I think the oxytocin.
Absolutely.
That's misoprostol or something. I can't really.
Yeah, so things that you might want to, you know, you might want to induce labor, mightn't you? You know, because there might be a small baby, or the woman might have got preeclampsia or whatever. So all of those things to start off labor, it might be. So you want medications that can help with contractions. So oxytocin, misoprostol, absolutely. Antibiotics. What else? Steroids, yes, brilliant. So that's in our fetal list, isn't it? We're going to need something for premature babies, and we know that premature babies are more common in conflict zones. So steroids available to be administered to the mother. We know that steroids makes a huge difference to neonatal outcomes, improving neonatal outcomes. So steroids, yeah. Tranexamic acid, brilliant. So tranexamic acid is one of the things that we can give in hemorrhage, can't we? And we know that hemorrhage is the leading cause of maternal death. So tranexamic acid, absolutely. Your oxytocin, your misoprostol, those also can help with contraction after birth. Magnesium sulfate, yes, so that's given again for the baby's neuroprotection in the context of preterm birth. Yep, what else is magnesium? Yes, magnesium sulfate can also be used to treat seizures in the context of eclampsia, or in severe preeclampsia to try and prevent seizures. Absolutely. Antihypertensives, absolutely. Second most common cause of maternal deaths worldwide. So antihypertensives, absolutely key part of your part of the medications that are completely necessary. Epinephrine, yes. What else? What else about childbirth? Think about the number of cesareans, for example, that have that are happening. What medications do you want for those? Anesthesia, that's right. Local, you might want regional for neuraxial analgesia, but also general anesthetics. That's right. So you want anesthetic agents, don't you, available? What else?
I think also antibiotics.
Antibiotics, crucial. Yeah, yeah. I mean, you've got so many reasons for problems, haven't you? For infection risks, and so antibiotics, and you need the spectrum of antibiotics. You also need to be able to test, don't you, to be able to know that you're giving the right antibiotics, but that may be more difficult. Tocolytics, yes, possibly, although tocolytics themselves, I would say, tocolytics, so medications that stop contractions, I think you've got to think why you're giving a drug that potentially is quite dangerous, and stopping preterm birth. There may be a very good reason why preterm birth is happening. So tocolytics maybe to transfer to a place of safety, or a safer place, may be appropriate. But tocolytics, stopping labor, you have to think why labor is taking place prematurely. It may be that there's chorioamnionitis. Now that's life-threatening to mother and baby, and therefore you wouldn't really want to stop the preterm birth. So tocolytics, yes, absolutely, they have a place, but they may need to be used with judiciousness. Anticonvulsants, and anticonvulsants for women with epilepsy, absolutely. We don't use anticonvulsants in the context of eclampsia, because we know that it doesn't work, and it doesn't it's not effective medication for stopping eclamptic seizures, because their pathology is different. But epilepsy, absolutely, women still have their medical problems. So non-communicable diseases don't go away just because there's a conflict or just because there's pregnancy. So insulin for those diabetic mothers, anticonvulsants for those women, or anti-epileptic drugs for those women who have got epilepsy, and all the other medications that might be necessary for all the different diseases that people may have and continue to have in pregnancy. So we've listed a whole load of things there. Yeah, so absolutely, antiseptics, ability to be able to alcohol, cleanser, to be able to wash your hands, clean drapes, chlorhexidine, umbilical, for umbilical cord care, cord clamps. When I was in Al-Aqsa, there were a number of babies in the neonatal intensive care, in the neonatal unit, whose umbilical cord clamps were in short supply, and they had their cords tied with string. Now you can tie them with string. Perhaps it wouldn't be your first choice just from a hygiene point of view. It's perfectly effective. But yes, so cord care, that's right, because women, particularly with being discharged from hospital so quickly, and that is definitely something that happens in these contexts, partly because hospitals are overwhelmed. You need to get women out as soon as they've had a baby, and trying to prevent anything that might cause neonatal infections, including good cord care. That's right. So I have got a list of the medications and that WHO recommends. Let's have a look how we've done. Oh, she says, no, I can't share. Oh, 1 second. Sorry, I've just come. Right, sorry, this is a bit small. I'm not sure if you can see it. But these are the sort of health interventions that are recommended on that list of key commodities. So alcohol-based chlorhexidine, well done, the person who said that. Aspirin. So aspirin, we know, can reduce the risk of preeclampsia in higher risk women. So aspirin is listed. Antibiotics, penicillin there you mentioned, particularly against group B strep. Calcium, and that's in supplementation. We know that in areas, and it's obviously context based, but in areas that have low, where women have low intake of calcium, that giving calcium supplements may reduce the risk of preeclampsia. Calibrated drapes, I don't know if you've seen them, but some kind of measure of blood loss, because we underestimate hemorrhage at birth, and having some kind of collecting system, even if it's a bucket that you can then measure in measuring jugs of what blood loss is happening, may help you with your managing a postpartum hemorrhage. Dexamethasone or betamethasone. So as we talked about the steroids, didn't we? And then there's also equipment. So things like listening into the fetal heart, either maybe a Doppler or a fetal stethoscope. Testing for infections, screening tests being available for HIV, syphilis, and also the drugs to treat those things. Iron, folic acid, ergometrin. I don't think you mentioned, I think we talked about oxytocin and misoprostol. Ergometrin is another drug that causes uterine contractions, incredibly effective. Carbetocin. So this is heat stable. So whereas oxytocin and ergometrin both need to be kept cool, carbetocin is much more stable and can be is much easier to store without it being degraded. Hydralazine, treatment of severe hypertension in the context of severe preeclampsia. Vaccines. So I think you've mentioned all of these. Labetalol as a antihypertensives, delivery equipment, forceps, ventouse, surgical equipment for cesarean sections, and aspiration equipment for women having miscarriages. So I think you did incredibly well with all of those things. There's one at the end here called uterine balloon tamponade. That's a way of putting a balloon inside the woman's uterus that just applies pressure, particularly to the placental bed at the time of birth, and it's something that can be used to prevent hemorrhage. So I think you did. I think you've done absolutely brilliantly. And then the things for neonatal health. So again, as simple as iron, mothers who are anemic or nutritionally deplete, it will be very difficult for them to breastfeed. And many of the other things, but somebody mentioned vitamin K, absolutely, really important part of trying to prevent preventable deaths in babies. I'm going to stop sharing that. Right. I think we're at an hour, but any questions? What is your experience? I think this is, I think what are the things that any of you would like to share, or questions that you want to just put out for everybody, or comments? There are lots of things to read, and I would recommend there's some really, really good things. And there are the Lancet, as I'm sure you're aware, the Lancet series of all sorts of things, but one of them is about maternal and newborn health in conflict. And there is a fantastic series that was published in 2021. There's also a series about the vulnerable baby being born too early, being born too small, too small too early, and that was published in 2023. And there are a series of papers, and I'd recommend that those are both really readable, that those are really good places to go and look. WHO, look at their guidance on maternal maternal health, the recommended antenatal care, the sustainable health goals that took over from the millennium, the millennial goals. Those sort of things are resources that I would recommend that you go and have a look at, because they give some incredible information about what is sort of recommended. Gauze, cannulas, cotton, absolutely. You need, we need drapes, you need gauze, you need suturing equipment. Do you recommend some emergency herbs in case no medications are available? I don't know enough about them. I mean, there are herbs we know that can cause uterine contractions and uterine relaxation, but I'm not enough of an expert to be able to, to value on those. Is it recommended to do a CTG without maternal complaints just to check fetal health? So it depends on our population, but in low risk women, doing an admission CTG, for example, in labour has not been shown to be beneficial. However, I'm not sure that you could describe any mother in a conflict zone to be low risk. I know WHO currently suggested about 30% of women entering labour the women in pregnancy are classed as high risk. I don't know how you can class anyone as anything other than high risk at the moment in what's happening in Gaza, but so a CTG, number one, availability of equipment, particularly with the impact on hospitals, the difficulty with access, with patients, having to move at short notice from one healthcare provider to another because it suddenly becomes unsafe to be in one hospital. So there is difficulty around equipment. A CTG can be useful, but there is a issue about who do you prioritize to do a CTG. And so number one, you can only do a screening test if you've got an intervention. So in birth, yes, it may be very useful, and you need to, if resources are short, you need to reserve it for your highest risk women, where you may be where it may help you decide on an intervention and the timing of that intervention. But for women at lower risk, it hasn't been shown to improve outcome, but intermittent auscultation in labour. Obviously, we're not advocating for labours that are unmonitored. Just the CTG has not been shown to have any advantage. Any other questions?